to a good debater, you could prescribe an antibiotic for a viral infection to suggest that you want to prevent a secondary bacterial infection. To a child who has no infection, you call it a prophylactic antibiotic. So you could prescribe antibiotic to each and every one and seem to justify it. Let's see where we are now in this situation. The present scenario in clinical practice is ideal antibiotic therapy so rare, simply because we have a problem of confirmed bacterial infection, and we really need to use prophylactic antibiotics only in very selective situations. It cannot be a prophylaxis against every possible infection, and I think a prophylactic antibiotic is a very, very strict consideration and not the general universal prophylaxis at all. And therefore, I think most of the pediatricians would use empirical antibiotic therapy, which is based on personal observation and practical experience. We know what it means really, that it's all experimental, it's all speculative, it's conjectural, it's hypothetical, it's assumed that you are treating a kind of an infection with the right antibiotic. And I think therefore, we really need to get on to a very judicious use of antibiotics with justification. What are the prerequisites of starting an empirical antibiotic therapy? I think in our situation, a rational antibiotic therapy needs to be addressed to really an empirical rational antibiotic therapy, for simple reason that majority of the times a clinician in his office practice is devoid of confirming a bacterial infection and maybe a drug sensitivity and choosing a right kind of an antibiotic each time. And therefore, we need to be very, very clear what is the prerequisite of an antibiotic therapy in your office practice. I'm sure a good history and a physical examination often might give a clue, but many times there may be an absence of clue to a probable diagnosis. I'm sure each time you see a patient within the first 2 or 3 days of onset of fever, much before the fever localizes to a particular system, you have no clue what you are dealing with. And I think it's at that time you need to evaluate the safety of observing a natural progress. This is the most important part of the rational antibiotic therapy, that if you do not have a diagnosis, and that you often don't in the first 2 or 3 days, you need to be very sure whether it is safe enough to observe the natural progress, which almost will unfold over the next 3-4 days. And I think you would know where you are. Many viral infections seem to settle by then, many bacterial infections would localize by then, and all that you want to be confident that it is safe to wait. And if you're not comfortable waiting, or even if you waited for 4 days and there's no clue whatsoever, then I think before you even consider empirical antibiotic, a minimal tests are mandatory so that you don't mess up the further progress in case you are totally mistaken on a wrong path. And I think in majority of the time the waiting would be safe. And to a child as a patient, we all know that he's not an adult, so he's unadulterated. He demonstrates his behavior of sickness. A child who has high fever and you give a paracetamol and the fever comes down and this child is running about and looks very active and normal, he's a child for whom you would very safely wait for a natural progress to define what the infection is going to come out with. On the other hand, a child whose fever may come down with paracetamol but remains a little sick, lethargic, irritable, not to himself as the mother would know, I think that's a child that you would like to watch carefully. And if you are now on a probable antibiotic prescription, it's very, very vital that you do some of the minimum tests, certainly to decide whether your antibiotic prescription that was empirically administered was the right one or otherwise. Many times an individual pediatrician in office practice may decide to investigate only if he fails on an antibiotic therapy. And I think that's not the way to go on rationality. If one is not sure, and one cannot wait. One must have a minimum investigation sent out. One need not wait to start an antibiotic, but one has to send out the lab reports and then take a judgment once the reports are through. I think in clinical practice, the most vital is to differentiate a viral and bacterial infection, and in our situation, maybe even malaria. I'm sure clinical medicine is so complex that no infection presents in a standard textbook way. And after all, the presentation of any disease depends not only on the bacteria or a germ, but much more depends on the host response. And you can have a varied host responses depending on the host ability, host immune status, host nutritional status, host mass exposure of infection. Therefore, there cannot be an easy standard way. Even then, if you follow a kind of a protocol and study yourself how often you would tend to go wrong, you would realize that even in routine office practice, it may not be very difficult to differentiate a viral from a bacterial infection in general. Well, most of the viral infections start with a high fever at the onset. Interfebrile period is pretty normal. You give paracetamol in the right dose, the fever comes down, the child looks very normal. Defervescence generally by day 3, day 4, and most of the symptoms are disseminated. A viral respiratory infection has a flowing nose, a congested eyes, a congested throat, and a bad cough. A bacterial infection in the respiratory tract, if you have a tonsillitis, your nose is not running, and you have nothing in the chest, and if you have a pneumonia, you have a localized finding. And I think even if you keep just such simple measures and use them in practice, you would find that majority of the times your judgment would get better and better over time, and you would be more and more rational. Well, the bottom line always is that you need to be very safe in doing all that, and we already said that you would otherwise rather consider a bacteriological or further lab test. I think CBC is a most commonly employed test, and I just want to drive a point here that more important than total count or a polys or a lymphos are some of the other parameters of a CBC, and that often are ignored. If you look at it, your total count and polymorphs go high in an acute bacterial infection, but they could also be high in a systemic inflammatory disease. So they do not justify an antibiotic per se. And if you look at typhoid as an acute bacterial infection, you often have a leukopenia with lymphocytosis. Therefore, where are you with a total count and a polys and a lymphos? And after all, if the polys go up, the lymphos come down, and vice versa. And to me, they are of very little importance. Far more important would be the eosinophils, the platelets, and the hemoglobin. And we would all see that in acute infections, often eosinophils would be suppressed. And I'm sure all of us try to diagnose typhoid by eosinopenia and lymphocytosis and total count getting low. Platelets often give you a clue where you are, like in malaria or in a leukemia, whereas in a systemic inflammatory disorder, you have a rising platelets. Similarly, the hemoglobin might give you a clue, and the point is, in CBC, the total count, polys, and lymphos take a back seat in your interpretation. Surely, they would have their own significance, but much far more important many other things. When you decide empirical antibiotic, therefore, you must have a high probability of bacterial infection, order relevant tests. These are the people on whom you would rather test quickly when you have a non-localizing fever. You have a young infant of 3-month-old with high fever. It's definitely dangerous to wait, and it's far more dangerous to write an antibiotic without justification. So you certainly get on to laboratory tests and then look at what's happening. And if you have, of course, a localizing symptom, then you might have a urinary or a respiratory pathology, and you could really look at that. Well, sometimes you may have a clinical judgment of a bacterial infection that may justify an antibiotic, like you have an acute lymphadenitis or an otitis or a bacillary dysentery, and then you know that you probably justify an antibiotic depending on a common community acquired infection sensitivity. I think another word about recurrent infections, that if there is a recurrent infection and if you want to write again and again an antibiotic, you are doing a much harm. No bacterial infections recur again and again in a normal host. Viral infections do. And therefore, if you have a recurrent bacterial infection, you must look at some background cause. It could be structural, functional, or immunological, and no use writing another antibiotic for another similar infection that comes in. What antibiotic? Always choose in office practice, a community-acquired infection, consider prima facie no drug resistance. If all of us practice rational therapy, drug resistance would go down. We are all responsible for that. And therefore, a single oral dose, for example. Well, if you have a complicated serious infection, then you might consider a parenteral antibiotic, and you might even consider a dual antibiotic. When you have a community-acquired infection, therefore, just consider what kind of organism you expect, what kind of host it is, and to that extent, multiple antibiotics could be only considered on the merits of this rationality. How long would you then give an antibiotic? Well, if I started an antibiotic empirically, and I've already sent out my lab reports, I consider 3 or 4 days as a reasonable period at which I must get a reasonable response as anticipated. For example, in typhoid, I may not anticipate the fever to go down, but in general, the patient would look better, and the fever pattern would show that it's on the decline. However, the fever may continue even when I have a successful treatment on. In case there is a failure of therapy, I think you need to assess complications. If you have a pneumonia that's not getting better, very likely it's an empyema that's developed, and just changing antibiotic, considering empirically that it was a drug-resistant bug, is again another mistake of irrationality. And I think always pick up a complication, but if you did not find any, then you might revise even your diagnosis, and time and again, acute bacterial infections are being treated, missing, say, tuberculosis, and then you are on the wrong path, and mere changing antibiotics is not an answer. What are the problems of empirical therapy? First is no documentation of provisional diagnosis. I think this is very, very vital. If you want to practice rationality of therapy, you have to put down a provisional diagnosis, however wrong it may be thereafter, but you must start with a provisional clinical diagnosis. Then only you have an antibiotic prescription. But what happens in common practice is all that goes wrong. And then you have a late diagnosis of a non-infective disease, and every systemic inflammatory disorder today gets 2, 3, 4 sets of antibiotics, and then somebody wakes up to say, maybe it's not an infection. You probably had a clue right to begin with, but you didn't pick them up, and you just went on irrationality. Many times the illness is prolonged because you're not using the best drug, and many times you suppress some infection, at the end of which even the laboratory tests fail to demonstrate what infections you are dealing with. Well, friends, then the rationality is such a need, and we all recognize it. But the trouble is, we seem to get away with irrationality. The time has come that antibiotics, newer antibiotics, will not come again and again. If you really see the newer antibiotics in the market, they are not new. They are just a little change in the chemical structure of an old antibiotic. So it's the same thing. And if we want to prevent that, it's much important we follow rationality. Thank you very much.